Tonight's event is supported by Scottish Government and PET are extremely grateful to them for their support. IVF success, what makes Scotland special? Now, I'd like to, for my introduction, just make really 3 points before we get started. So first off, as Director of PET, I apologise for the title. We used IVF as a shorthand for fertility services. So just to be really clear from the outset, we're not just talking about IVF this evening. Second, I make no apology for calling Scotland special. It leads the UK in helping people who are struggling to conceive to have a much wanted family. And third, Prime Minister Boris Johnson scuppered his chances of being on the panel this week with his comments about Scotland. For more than a decade, I've been observing what's been happening in Scotland with fertility services, and I can say with confidence that far from being a disaster, the services are a resounding success. So tonight we're going to hear how, why, and what makes Scotland special when it comes to fertility services. And we have 4 marvellous experts lined up for you. We have Sally Cheshire, Colin Sinclair, Abha Maheshwari, and Gwenda Burns. First off, we have a message from a member of the Scottish Parliament, the Minister for Public Health, Sport and Wellbeing, no less, Mr. Joe FitzPatrick.
Hello, I'm Joe FitzPatrick, the Minister for Public Health, Sport and Wellbeing in the Scottish Government. I'm delighted to have been asked by Fertility Network UK to say a few words during National Fertility Awareness Week about the provision of NHS IVF treatment in Scotland. Infertility can affect anyone trying to start a family. That's why the provision of equitable treatment is so important. The Scottish Government continues to lead the way in the provision of NHS IVF treatment, and we want access to treatment to be as fair as possible, giving more people the opportunity to conceive. In 2011, we set up the National Infertility Group to look at variation in provision of service across the NHS in Scotland. Expanded treatment criteria was developed by the group and implemented nationally to ensure that there is equity of access regardless of where patients live anywhere in Scotland. The national criteria provides eligible couples with up to 3 full cycles of IVF treatment, and a full cycle includes unlimited frozen embryo transfer cycles where these are available. Criteria was expanded by the Scottish Government as recommended by the National Infertility Group to include access to NHS treatment for couples where one partner already has a child but the other partner has no biological child. This expansion has further increased fairness in the service, giving even more people the opportunity to try for a child of their own. We've also increased the upper age limit so that couples where the women having treatment is aged between 40 and 42 can have 1 full cycle of treatment, in line with NICE guidance. The standard is set for treatment to start within 12 months of referral, and we've invested around £40 million over the past 5 years to help ensure that this target is met. The expanded criteria is implemented and other improvements are made. Fertility Network UK is a valued member of the National Infertility Group, particularly Gwenda Burns, ensuring that the voices of patients are heard in the decision-making process. The work of Gwenda and her team has been particularly crucial during the past 7 months as the COVID-19 pandemic has created uncertainty, and the need for patients to have a friendly and well-informed ear to listen to their concerns has never been greater. I'm grateful to the network for all the work that they've done during this time to support not only patients but also Scottish clinics. I'd like to end by saying that I'm proud that Scotland has the most generous and fairest NHS IVF treatment in the UK, and equitable access to treatment continues to be a key priority for the Scottish Government. Thank you.
And Sally is Chair of the Fertility Regulator, the Human Fertilisation and Embryology Authority.
And good evening, everybody, and thank you to Sarah and the PET team for asking me to speak tonight. I'm the only member on the panel who doesn't live and work in Scotland, but as Sarah said, I chair the UK Regulator, which covers all the home nations. So my job is to try and present to you some of the statistics which cover the UK and why Scotland is special. I'm sure that Colin, Abha and Gwenda are going to talk about why Scotland is special. So I wanted to pose a slightly different question, which Joe FitzPatrick touched on in his video, and that is whether Scotland actually leads the UK fertility sector. So just to give you a little bit of context, there are 136 clinics in the UK, with 106 of those offering patient treatment. Some of the others are for storage or research. Scotland has 7 clinics, the orange figure at the top of the screen. And Scotland delivers around 7% of UK cycles, around 5,000 out of about 75,000. Just in terms of UK context, around 80% of our clinics are given a 4-year licence, which is the maximum and which indicates good overall compliance. And 2/3 of the clinics that we regulate are standalone, with the rest of them owned by 10 private clinic groups. Most of them, as you can see from the map, are in London and the South East. So in terms of Scottish clinics, there are 5 main centres in the big urban areas, as you would expect, in Aberdeen, Dundee, Edinburgh and Glasgow. And all of those main centres are NHS centres, apart from GCRM in Glasgow. And there are also a couple of IUI units, Ayrshire and Lanarkshire, which offer IUI, intrauterine insemination. And there are a couple of centres that also store gametes, as I said before. The way that we focus on rating our clinics are through 3 different areas: an inspection rating from our inspectors through our compliance regime, a patient rating based on feedback from patients, donors, and anyone else who enters a clinic, and also IVF birth rate, what are sometimes called success rates. And the IVF birth rate that we show, so that you can compare clinics favourably without them cherry-picking statistics, is the birth rate, the live birth rate, per embryo transferred for women under 38 who are having fresh IVF using their own eggs. You'll remember from the previous slide that I said 80% of our clinics have a 4-year licence. It's important now to say that all Scottish clinics have a 5-star inspection rating, and all clinics have a patient rating of 4 or 5 out of 5, even though there aren't always lots of reviews to show you. You'll see lots of different websites that show patient reviews that give you tips on clinics, but the HFEA website shows independent verification of what treatment someone has had, how they felt about it, what it cost, whether they were treated with dignity and respect, all of the things that you would expect a patient to want to have when they were going through treatment. All Scottish clinics, again, it's important to say, are consistent with the national average success rate. There are no poor performers, and Glasgow Royal Infirmary actually has a higher than the national average birth rate as well. So just to talk about success, the UK average birth rate for people having treatment, unfortunately, is 23% per embryo transferred. That means that you have around a 1 in 4 chance of having a live birth per embryo that you transfer. The Scottish rate is 28% per embryo transferred, so you can start to see the success. And for that number that I talked about on the previous slide, for women having fresh IVF under 38 years of age, the UK average rises to 29%. Success rates are always better when you are younger, and Scotland achieves 34% compared to the UK average of 29%. So that difference is maintained both at younger ages and across the whole population. Around a decade ago, the multiple birth rate, which is the single biggest issue, health issue for mothers and babies, causing disability, low birth weight, all sorts of issues, and potentially a greater number of stillbirths. The multiple birth rate in the UK was around 24%. And we put a concerted effort behind a campaign to reduce that, with setting a target of 10% across the UK. Finally, from 2018 data, most of my data is from 2018, the UK has achieved that target for the first time, which is a huge public health success. And the UK average is now 8% multiple births in all of our clinics. Scotland has gone a little bit better and is at 6%. Many of our clinics are in single figures and below, but the Scotland average is 6%, something else to be applauded. I do think that agreeing NHS-wide policies and protocols, for example, on single embryo transfer, on a lack of need for add-on treatments that are very popular in private clinics, have made sure that Scotland is successful in doing things together. And as you heard from the Minister, there is adherence to the NICE guideline on access and funding. So my figures there show that in 2013, Scotland funded around 51% of treatment on the NHS, but that is now up to over 60% from 2018 figures. And on donor insemination, because Sarah did say we weren't just talking about IVF, then for same-sex couples, Scotland funded 70% of donor insemination, and for heterosexual couples, 47%. So 70% and 40% versus a range of between 5 and 15% only in the other home nations. So doing much, much better in terms of the equity of access that the Minister talked about. Just in terms of what I think's worked, the others will come to talk about this tonight in more detail, but I think there are some key factors. First of all is the cooperation between clinics and through the National Infertility Group, and you're going to hear from Colin shortly. I think doing things together and collaborating is absolutely the key to getting things right, because you learn from each other. There has been a consistency. I know that you don't all agree steadfastly on what the right IVF protocols ought to be, but that is a work in progress and much better than elsewhere in the UK. The oversight and commitment from the Scottish Government has been fantastic, and something that I talked to English ministers about, as well as having talked to the Scottish Minister about when we visited Scotland. The Scottish Government come to HFEA meetings, they're really supportive of what we do, and as you've heard, there is a concerted effort across the Scottish Government and also with Fertility Network UK, particularly through Fertility Network Scotland, to make sure that everyone works together in the best interests of patients. I think the fact that most clinics are NHS based, even though they treat NHS and self-funded patients, is that there's little distraction from competition and a very sensible approach to one of the things that we find most difficult, which is the use of add-on treatments. They can be costly, expensive and ineffective, but we appreciate that if you are going through treatment, you would want to try everything that you possibly could to be successful. Abha's going to talk more about the sensible approach to and the infrastructure for research. For example, Scotland led on the fresh versus freeze-all trials and has taken part in the National Institute for Health Research funding projects on HabSelect and EndoScratch. As I said before, the final criteria is that adherence to the NICE guideline on funding and equitable access is well known in Scotland, and by patients, government and clinics alike, I think, means that there is more adherence to it. So has it worked during COVID as well, this continued success and the special features of Scotland? As you know, all NHS fertility services were paused back in April. We took a decision to do that when other NHS non-emergency services were also paused to avoid overwhelming the NHS at a particularly difficult time. There was a 6-week pause from when we allowed clinics to reopen, and the Scottish Government, Fertility Network UK and Scotland, and the 4 NHS tertiary clinics have been working on a uniform approach to policies and documents, a phased restart plan. Most clinics are now, in fact, all clinics are now open, seeing around 80%, I believe, of patients. There is a winter plan, and there is no proposal for us nationally or for Scotland to try and close down clinics again, even though, as Sarah mentioned, there will be further restrictions I'm sure we'll see over the next few months. I think there's been a really sensible approach, putting patients back at the heart of where we are, prioritising them during this gradual move to full reopening. So although we will expect to see a different set of figures for 2020, you can be reassured that Scotland is still leading the fertility sector. I was asked to present a challenge despite all the positive news. And I think my challenge for the future would be about improving the number of items of patient feedback that are around on the HFEA website attached to Scottish clinics, because Scotland has, the Scottish clinics have up to 20 reviews per clinic, but more often than not, single figures or around 10. And some of our best UK clinics are approaching 200 separate pieces of patient feedback. So if you're going to do something to show why and how Scotland leads the way, then I would plea for it to be about patient feedback. Thank you very much for listening. And of course, I'm happy to take questions later.
Colin is the Chief Executive of NHS National Services Scotland, and importantly for tonight's event, he's the Chair of Scotland's National Infertility Group.
Sarah made a mistake at the beginning. She said there was 4 experts in the panel. I would say there was 3 experts and me, who just happens to have the very pleasurable job of chairing the National Infertility Group. I don't have a background in this area at all. I'm a procurement and logistics specialist by background, so it's really been a pleasure to be involved and to see the magnificent work that goes on, and I'm sure not just in Scotland but across the UK, but I certainly see Scotland and the impact it has on people's lives. So I say delighted to be here. When I saw the heading, I kind of thought I have to look at the second part first, what makes Scotland special, and forget IVF for a wee minute. So clearly, I think what makes Scotland special is our welcome. I think Scots are renowned for their hospitality. And without touching too much on COVID-19, that's just got a temporary ban at the moment. So please be very careful if you're coming to Scotland for a welcome just now. Clearly, we're well known for our scenery and for Harry Potter fans, the film sets as well. You know, as I say, Scotland would very much want to welcome people all the time, just probably more challenging at the moment. One thing we're absolutely famous for is our weather. One of the things I've learned from working from home is you really can see through your window 4 seasons in one day. And this picture is a very apt example of what Scottish weather can be like. And lastly, as a football supporter, how we celebrate 22 years of not qualifying for a competition for the men's team. So lots of celebration to come. So on a more serious note though, what does make Scotland special from an IVF point of view? And I think firstly, just to set the policy context, which the Minister did quite a bit of earlier on. But I think for me, it was first of all recognising fertility as a treatment that was an entitlement of people in Scotland through the NHS. And if you then build from there about standardising access, equality of access, you invest in it, and you set some sensible treatment guarantees and goals that give it the importance that it deserves within the myriad of other services that NHS Scotland has to provide. Sally focused on a lot of the figures, which I think are excellent and show the success. I just want to talk through some of the reasons as to why I think we've got to where we are in Scotland. So the first priorities were about delivering on policy, and the Minister touched on child in the home and third cycle. When I first took on chairmanship of the group, this was a major priority and was the kind of #1 task for us. I think it's really positive that this is now very much in business as usual, and the centres, you know, work with on the third cycle principle and child at home, and it's not been overwhelming to their work, which was a concern in the beginning. Waiting time standards have been set. Patients need to be seen within 12 months. We clearly want to do better than that. And in the centres we have, COVID has clearly had an impact. But as you can see, for 11 quarters, we've succeeded in meeting that treatment guarantee and been actually well below it, not just beat it. And also last, but just the IVF focus on the infertility group, which brings everyone in Scotland together. But as Abha will talk about later on, we've now developed a fertility network, which will hopefully provide a group of an area of expertise that can take some of the thoughts and requirements and actions from the fertility group and put them into practice. So as a fertility network, what is it that we're trying to achieve? I've always felt, just when you're running a group like this, what is our overall aim? And tried to sum it up in these 4 slides, 4 bullet points, I should say. First of all, and been mentioned before about collaboration between the 4 centres. We've 4 excellent centres across Scotland from an NHS perspective. And the route to success is to share best practice, drive up standards, make sure we're doing things where it's appropriate in the same way, and a consistent approach all round. And we're moving in that direction, I hope, without losing the very appropriate at times local knowledge, local understanding, local expertise. So it's always trying to find that sweet spot. A Once for Scotland approach to improvement and consistently high quality. And that, I think, was helped to drive the figures that Sally presented earlier on. And I'm very much a believer in that continual push for service improvement and step changes, as I'll talk about in a minute. Critical to have a focus on patients and outcomes, and Gwenda's presence on the group always make sure we keep the patient in mind, although my colleagues around the NIG continue to do that, but certainly having Gwenda's input there is very much making sure that's front and centre. And again, the last thing is just that equality of service, and ensure that no matter where you live in Scotland, you get the same treatment. We avoid the risk of any kind of postcode lottery. What's our current areas of focus? I mentioned a wee bit earlier on the Scottish Fertility Network, and that is about trying to look at how we can push forward with some of the changes, initiatives we want to achieve, and to bring together stakeholders from all across Scotland, whether it's patients, clinicians, or other government colleagues, and I say Abha will talk about that. I'm going to just skip to fertility preservation and consent. This is an area of focus and growth with us at the moment. It's clearly very important, particularly for young people. If you've got, from oncology, from transgender people, that fertility preservation is a service that becomes available and that can be delivered effectively. And actually, one of the few benefits that have come out of coronavirus is we can now do online digital consent, which is a significant step forward and something that we can clearly keep using post-COVID. Yes, there will be a post-COVID world, believe me, that everyone can use. What that's also led us to is the National Storage Centre for Gametes, which I'm delighted to say is in the Jack Copland Centre, which is the headquarters of the Scottish National Blood Transfusion Service, which is part of NSS. And that's going to provide a kind of modern Once for Scotland storage facility for gametes, and will be supported in the spring and summer by hopefully a very strong advertising campaign to try and get more gametes donors, which we do need at the moment and would have been launched by now if it hadn't been for COVID-19. As a chief exec, you would understand I'm always going to have to talk about money, and we've done a significant amount of work with Glasgow University and with colleagues across the centres about establishing a cost for IVF and for the various different treatments within IVF. And that will help on a range of things. It help in our resourcing, help understand what we can afford and what is going to be challenging times, understand each of the treatment cycles and how much they cost, and trying to drive consistency and efficiency. And, I can never apologise for that. It's not an absolute standard because all our sites are different. They're in different buildings. They've got different issues and challenges, but it does give us a very strong base. And the last item we're working on is just access criteria, and what should that be in the future, and what would that look like in the future, and how do we influence policy, and whether it's around things like access to people who have had sterilisation, or single people, or through secondary infertility issues. So it very much areas that the National Infertility Group is talking about. So what next? I try to avoid as much as possible talking about COVID-19, but I really think a big thank you to everyone in fertility in Scotland for keeping services going in very challenging circumstances. And we will continue to work around the issues that COVID-19 presents, and can be particularly challenging if you're losing staff, but so far, to other areas of activity, but so far we're being successful. We want to, as you would imagine, continue to increase quality of care on a constant basis. We do need to recognise there's a financial envelope that we have to work in. COVID-19 will impact our costs and our available funding in the future. But I know Scottish Government are committed to ongoing support. But within fertility, we need to make sure that we're driving we're as efficient as we can be, because there's lots of other services that pull on our cash, and collaboration and best practice is a clear way of doing that. And as I say there, we've got an excellent knowledge base and expertise within the NHS in Scotland, and building on that to deliver improvement in the future is key. So just to kind of finalise, and I think other people have talked about this before, what does make Scotland special? 4 excellent centres working together, and increasingly working together, not just sharing best practice, but supporting each other. As I mentioned earlier, strong patient representation, investment, which is clearly key, and I'm delighted that Scottish Government, despite the financial challenges I've talked about, are going to continue to do that. And really, just as I say at the bottom, the dedication of the teams throughout Scotland. And to me, the challenge for me is that as a team, how do we take infertility to the next level? You know, they're never the best analogies, but 15 years ago, we all thought mobile phones were great, and they were the best mobile phones we've ever had. We now all work in smartphones and couldn't live without them. So what's the step changes that we can try and deliver over the next 3, 4, 5 years that will take IVF to the next level? Thank you.
So next up is Professor Abha Maheshwari. Abha is the clinical lead at the Aberdeen Fertility Centre, and she is also an honorary clinical senior lecturer in reproductive medicine at the University of Aberdeen, and importantly, she is the lead clinician for the Strategic Fertility Network in Scotland.
So what's so special in Scotland? And you asked me to speak about the clinician perspective. So I started my current job of lead clinician for Strategic Fertility Network just a couple of weeks ago. And we've also got a lead scientist who is Joanne, who will be starting the job soon in January. So what's so special in Scotland? Well, there are a lot of things which are special in Scotland. I'm not for Scotland, but I came here and stayed here because, as you can see, there are lots and lots of special things. It's a beautiful place and just nice to be here, and delighted to be here. In terms of what Colin mentioned, that we worked on a lot of projects together as part of National Infertility Group. We worked on improvement plan where we collated the data from all 4 centers. We did work on the cost, and we realized that there were variations. Variations were identified, and with Colin chairing with his procurement hat and Once for Scotland hat on, we thought what we are going to do next. So there were willingness to collaborate, that we need to minimize the variations. We can't completely eliminate it, but there are processes that we can minimize it. How we can do it? So we put up a business case to National Service Scotland. It went through 2 stages to have a network so that we can all work to same principles, same protocols, because it needs a governance structure for which we needed a network. So both those applications went from stage 1 to stage 3 and was approved last year in November. And we had the existing expertise, and that's how we asked for the network, because there are already existing well-established network in Scotland, So there is an existing governance structure, and the oldest one is the trauma network, which is an exemplary network leading on to other networks, including the perinatal networks. So we don't have a logo of Strategic Fertility Network yet because it's just starting right now and we're working on it. So I can't show you the logo. And how did this all started was that the confidence we had in able to work together was that we worked on various documents, including the example I would give you is the donor profile and health questionnaire and all the donor documents. As Colin mentioned, we now have got a Jack Copeland Center, which is a national storage center with SNBTS. So with SNBTS colleague, which is a Scottish National Blood Transfusion Center, we worked on how we are going to recruit the donors and what questions we are going to ask them. We realized that all 4 centers have different questionnaires and different processes. So we collated them all together, collated everything else which was available in the Word, created a health questionnaire for donors, had the feedback from all the centers, from the colleagues who were part of the group. They fed back through the centers. The whole guidance was created. As you can see, it has logos of all the centers as well as NHS Scotland. This was then fed back to all the centers. So it went to and fro number of times, number of iterations, but at the end, there was a good product. Any donor coming in through Scotland fills up this questionnaire. So it's exactly the same. Now, when they fill up this questionnaire, it depends on whatever they answer. So we created a guidance for gamete donation in Scotland as to whether they'll be accepted, they won't be accepted, what we need to do so that everybody is doing the same thing. This is equivalent to the JPAC that blood transfusion and blood and tissue folks have. So this is the first sort of this very, very detailed guidance alphabetically for every condition. And these were the kind of success stories that we had. And we worked with SNBTS. We learned a lot from them. They learned a lot with us. So there was a lot of collaboration going on there. COVID, in the era of social distancing, we were much closer. All 4 centers and representatives, not just the clinicians, it was clinicians, scientists, quality managers, Gwenda as patient representatives, as well as the clinic managers sat together and had regular meetings, initially twice a week, once a week, and now we are meeting twice a week, once in 2 weeks again. And when the HFEA announced that we can reapply for license after initial closure, we actually had the strategy almost ready as to how we are going to plan in the post-COVID or when we are allowed to open. So this strategy is published on the Scottish Government website. All of us used it for applying to HFEA license. And there was a lot of information given in there as to how we are going to risk mitigate, how we are going to minimize the virus transmission, and how we are going to work in the post-COVID or in the COVID era when we start to open. We also did the patient webinars so that we can explain to patient or update patients as to what's happening behind the scenes. Even the smallest things such as cervical smear, if patient is not ready with cervical smear or not updated because we know screening was stopped with COVID, we took it to the next level. We asked the relevant people, and there is a flow chart in this so that everybody abides to the same thing. Once the strategy was published in July, we were then preparing on the winter plan because we knew winter was coming. We knew there is a risk of second wave. And actually this was published last week, and actually it came very handy. Now, you know, some of the councils are in stage 4 area, but this has a chart where what can we do when we go to level 4? What can we do when we go to level 3? So again, that is coming in very handy. But a lot of work is going in there from everybody who was part of the group, and again, the clinics who have fed back on that. The other things that we are working on together are the storage protocols as to how we do the recall system, how we manage what letters go to patient when, and how we deal with it. Again, this is being led by Joanne, and we are all kind of working together on each sentence. Each word gets kind of checked with everybody, and we agree on something. And only one for Scotland, one protocol will be used. And where advice is needed, we take the advice. Alison McTavish is leading on consents. As Colin mentioned, very quickly we realized we needed electronic consent national procurement from Scotland helped, and we very quickly went through the whole procurement process. And now a group of colleagues is working on the consents. 20 consents have been agreed on together, and all the differences between center is the different logo of each individual center, but we'll be getting those electronic consents soon. We have regular complex case discussions twice a month, every time any complex case is brought to this MDT, and then we make decisions so that there is a governance behind that. And as Colin already mentioned, fertility preservation documents are being worked together, led by Richard Anderson, who is the world expert on fertility preservation. It is great to see all these work going on together. Everybody inputs their time, their effort, feedback on these, and that's why we can work together. Now, we heard that it's not just about IVF. All the work up till now has been quite a lot of IVF focused, but Strategic Fertility Network is going to take it to the next step. It's not just about IVF, it's the whole patient journey. And the journey starts from when they start to try, or when you plan the conception. So we have to have preconception optimization, and public health need to be involved in that. Right people have to be referred from primary care with right investigations to the secondary care at the right time. So we'll work with the colleagues there to have that streamlined. And so it's not just about IVF, which is much later, but right people for the right treatment at the right time with the right treatment, I think is the very important. But all these pathways need to be standardized. We'll work with various colleagues from maternity, because whatever we do in the fertility have an impact on maternity, have an impact on units. We'll work with oncology. We are already working with genetics for pre-implantation genetic testing. And we also need to be aware about that whatever we do in fertility treatments, not just IVF, all other fertility treatments have an impact on long-term health. So we need to improve the long-term health of the next generation. So all these pathways will be developed, worked, and streamlined as part of Strategic Fertility Network. A lot of work needs to be done. There will be a lot of hurdles, but we know we don't say that it's not going to happen, but we say how we are going to make it happen is what our motto is. And the pillars of work that we'll be working on with Strategic Fertility Network will be clinical governance, education and learning for all the staff. And it's not just the staff, but it's for the patient education as well, because infertility could be prevented in a lot of cases. So prevention of infertility will be a major pillar. As Sally mentioned, patient feedback. Patient feedback will be a separate pillar, and we will work with Gwenda and other patient groups to work on that so that we can have patient feedback to improve the services, because services is for them. It's them at the center, and we are working for them. Research and innovation. Scotland for fertility research is absolutely at the forefront of it. All 4 big centers in Scotland are absolutely renowned for research and innovation in fertility. They've all got their areas of strength. Edinburgh works on fertility preservation, Glasgow on big data, Dundee on male infertility, and Aberdeen on various prediction models with big databases. So there is a lot of big trials which have come from Scotland, as well as we participate in all the trials that are led by other places as well, including England. We also will work on the data and audit with streamlining our data so that all 4 centers and all other centers could contribute to the same data, and we work on the same principles. As I say, we all have shared vision. We all try to work collaboratively rather than in competition. We share a lot of good practice, and it's always so nice to see that we all work together, because we know where we want to reach, and with the shared vision, we are all kind of putting together so much effort. It's so much collaboration. It's just absolutely fantastic to see. And it's a great, great honor for us to be part of this journey with everybody else. So thank you very much.
Finally, now we have our last speaker, someone we've heard quite a bit about in different presentations, which is great, and that is Gwenda Burns. And Gwenda is the Chief Executive of the leading charity for fertility patients, Fertility Network UK.
Thank you, Sia, and thank you for inviting us along tonight. So I've been asked to speak about what the situation was in Scotland, what it led to such good access to treatment, and how it is continuing. So 10 years is a lot to try and fit into a short time, so it will be a brief update, but I will try and cover as much as possible. So I'd like to say to start with that for the last 10 years, patients have been absolutely at the heart of all the work undertaken and everything that's been achieved. I can honestly say that. But to answer the question and what makes Scotland special, you actually need to look back to 2010. So pre the National Infertility Group being established, Scotland's fertility service provision was very much how England is now. It was a postcode lottery. Although the minimum cycles being offered at that point were 2. So eight health boards provided 3, with the remaining 6 providing 2. Although I say that with some caution, as the definition of a cycle varied. Waiting times were well over 3 years in some areas, and in one health board, following an unsuccessful cycle, you were put to the end of the waiting list. Over many years, Fertility Network campaigned on behalf of patients for an equitable, fair provision of service, which undoubtedly helped in the establishment of the National Infertility Group. Politicians and the Scottish Government recognised and supported a need to address the inequalities and established the group, which brought together 24 people from service representatives, key national bodies and stakeholder representatives to provide their knowledge and advice to develop existing and evolving policy. Areas included the waiting times, definition of a cycle, effective person-centred pathways, and recommendations of access criteria across Scotland. The work involved a huge commitment, and I can't emphasise that enough. It was huge and still is a huge commitment and dedication from all the members. There were also subgroups established to look at different areas such as research, carry out data modelling from an economical point to the potential impact on clinic capacity of any change in recommendations, and also to hear from experts in other areas such as obstetrics. It was important, yes, that any changes would be equitable and fair, but also that it was based in clinical evidence and that the system would be sustainable. There were different challenges at times over the years, but these were always overcome through listening, working together and reviewing evidence. By September 2012, it had been agreed that there was an urgency to reduce waiting times as soon as possible. The Scottish Government announced an additional £12 million would be made available over a 3-year period to reduce these to a maximum wait of 12 months. And by 2013, recommendations were agreed by the group and the report was published, which included new provision if aged between 40 to 42 and met some additional criteria. 1 cycle of treatment could be accessed. The report also recommended that eligible patients may be offered up to 3 cycles of IVF, where there was a chance of a reasonable expectation of a live birth. However, until equity and waiting times reduced across the country, the group recommended up to 2 cycles. I can't say as a charity that we didn't worry that the full recommendation would be reached in the future, but we acknowledged and recognised the reasoning behind the decision. The charity continued to raise awareness, campaign and gain further support for the introduction of all recommendations, alongside securing commitments within manifestos. We were absolutely delighted in 2015 when the group reconvened to review the progress and consider introducing the criteria that had been postponed. When the group met, some members had changed as some people had retired or moved on, and it was a worry that their vision may not be the same as the original group. With that said, by 2016, the group recommended further criteria should be implemented to allow couples where one partner had no biological child to access treatment. And from the 1st of April 2017, the final piece was introduced where couples could access a maximum of up to 3 cycles. This meant Scotland had what is referred to as the gold standard of IVF treatment in the UK. Following all this work continued, and the group still, as it already has been addressed, continues to meet, with subgroups continuing to address and ensure equity and improve areas again which have already been mentioned, such as fertility preservation, donor treatment, storage, the work around the National Centre and the new network. It should, and it's important that it is recognised that the Scottish Government has continued to provide further investment into the service. The work and dedication which has gone into the area of IVF services has ensured Scotland has the fairest and most generous provision in the UK, with work still continuing for patients. There now are only a handful of members of the original group who still remain, and over the years, as members left and new people joined, we didn't actually need to worry, as they have been equally as dedicated, passionate, sharing the same vision for the service. The answer to the question, what makes Scotland special? Well, I do feel I need to mention a couple of other things first before I touch on IVF success. So the original James Bond, Andy Murray, penicillin, Lewis Capaldi, and really how would we all cope without the invention of the telephone? But from the IVF success points, from the support of the Scottish Government, to the politicians, to every single person and patients who have fed in to the national group and subgroups throughout the years, it has been and still is the people involved that has made Scotland special. Thank you.
How does the online consent work, and how do you ensure that there's no coercion happening behind the computer screen? So Abha, if you could answer that first, please.
Thank you very much. Oh, yeah, it's a very good question. The online consent. So online consent platform is being introduced. It's not live yet. We are still working up with the implementation plan right now. So the way it works, it has got a number of steps to ensure security, that the right person answers, there are code being sent, so that there are a number of steps being taken. And all these things were part of the procurement and checks for the procurement when we did, because IT folks were involved as well. So all those things are being taken in consideration when they are being sent. So online, they get sent to patients, patients fill it, they get alerted, they have got a lot of information that they read before they fill it, and they send back to the clinic. So it all happens online. And those who can't answer this, the online and have difficulty in online, there are videos in there. They can actually, and there are subtitles, those who have difficulty in reading the videos as well for their information in there.
And are there any clever things in there? You just can't just skip without reading the small print when you're doing this, and you can't just consent to things willy-nilly, so to speak, because you know, with other online forms that you do, you think, oh, I'm not going to read the terms and conditions and all that again. Just tick.
No, it gives you a lot of information beforehand, and it actually also tells the clinicians or whosoever is checking the consents that how much time patients have spent in reading that information. And it actually has got questions and a quiz to answer to check your knowledge as well. So you can't just willy-nilly sign it.
Cunning. Sally, I can see you smiling. Is there anything you want to add on there? Is this something that the HFEA has looked at, whether they need to have anything in the code of practice about these sorts of consents?
We are considering electronic consent at the moment. It's used by a number of different clinics and it's becoming more popular. It will have to go into the code of practice in more detail, but we didn't particularly want to recommend, you know, a software provider at the moment. There are a number of them out there. So we're going to see how it rolls out. And as Abha said, the important thing is that there are constraints on anybody signing willy-nilly at the moment. It actually takes away the need for patients to go into a clinic, particularly during COVID, but even before that, to sign every single document when clearly some patients live a little bit further away from the clinic that they might go to.
Yeah. Gwenda, is this something that you think that patients will welcome?
Yes, I do. I think absolutely.
Oh, Gwenda, you've muted yourself again. We could hear you and then you suddenly went on mute.
Sorry, I think definitely, and just to echo what's already been said, and I don't think there could have been a more appropriate time for this actually to come along under the current circumstances, but I definitely think that it will give people more of an opportunity to read through the consent and look at the videos, which will help inform them.
Great. Colin, the question was directed to you. Have you got anything to add to this?
Nothing specific other than just to, I think, recognise Gwenda's point in everything the NHS is trying to do at the moment. There is an awful lot of emphasis on utilising digital technology, which is kind of two things, both recognising the challenges of COVID-19, but I also think trying to have a service that's much more responsive to a lot of what patients would want to see. They would want to use online technology. They're used to using it in their day-to-day lives. That doesn't mean that there isn't a whole group of people who don't and can't or won't. So it's not a fix-all for everybody. But in the current environment, and I think going forward, it's a lot of how people will want to engage with NHS services.
Yeah, I think there's also, perhaps for me, the one thing that strikes me is about there not being then reduced opportunity for patients to have the conversations with the clinicians and the nurses along their sort of treatment pathway, because that would be a shame if that were lost, because too much is done on, on forms. I don't mean not through telemedicine, but through forms. I think it's key. So I'm going to move on to the next question, which is one for Sally, and that's from Marco Gaudion. Oh, sorry, Marco, now I've pronounced your surname wrong. It's very embarrassing. This is about the headline success rates on the HFEA website, something that people get very excised about. And so saying that it's for women of under 38 years of age, and that's the first thing that people see. And then this can put some clinics at a disadvantage, particularly perhaps those in the private sector where they may be treating older patients or patients who are then not eligible for NHS funding and therefore older, etc. And so why can't the HFEA present the headline success rates for different age bands on the front page like they used to do, he's asking.
Okay, well, I completely understand where Marco is starting from, and there are a number of clinics who fall into that category who may well be treating older patients who may have been treated on the NHS and then come to the private sector later, maybe if they've been unsuccessful. We used to have age bands, and a lot of the feedback was that they were quite confusing. So the change was made to try and make it simpler, although I realise you can't please all of the people all of the time. The other change is that people access the HFEA website and all other websites now on their phone. And it's actually very difficult to scroll down a whole series of different tables when you may be looking at that kind of information on your phone. So there were a number of ways that we changed. That base information is still there. And the reason we chose fresh IVF under 38 is that that covers 2/3 of all patients. So that group of patients, single women, couples under 38, covers a large proportion of the population.
Thanks for that, Sally. I don't think I'll go to the other speakers on that unless you're burning to jump in. So I'm going to take the next question, which is again for you, Sally, of Popular this evening, or I think this will be something that Abha might want to come in on too. So this is Ellie McMillan. I'd be interested to know if there's a difference between the rate of incidence in Scottish clinics, so that's for people who might not be aware where things go wrong, compared with the rest of the UK, and if it's lower, do they apply different ways of learning from incidents, e.g. a human factors approach, in order to prevent their reoccurrence? So if you answer first, Sally, and then we'll go to Abha.
Yeah, I can comment generally, not specifically about Scotland, which is where Abha may be able to help. So it's important to say that the number of incidents, we do encourage a learning culture where clinics report all of their incidents to us, ranging from something very serious, of which there are only normally 1 or 2 incidents maximum a year, and often none at all, where embryos or women undergoing treatment may be harmed, for example, through to slightly less serious incidents, and then things like administrative, what we call grade C incidents, where, for example, it can be very hurtful if you send a letter to the wrong address, but nobody is harmed. So we categorise our incidents into grade A, very serious, grade B, and grade C. The number of incidents we have every year is about 550 to 600, which sounds a lot, but it could be, the rate is 0.7%, around 7 incidents in every 1,000 cycles. And it could be as simple as an administrative error. We've seen in 1920 the number of incidents go down by around 8%. The areas where we have most incidents across the country are in medicines management, around drugs and drug control and drug prescribing, around quality management in clinics, and around consent that we just touched on with the question about electronic consent. So I don't know if Abha's, we publish our State of the Sector report, which talks about incidents and where they happened and what type they are, but we don't specify by country or by region. So I don't know whether Abha's got any anecdotal evidence about what Scotland are good at, but also the types of incidents they've seen.
So as Sally, you said that we don't have a separate incidents for Scotland. All I know is that we submit all the incidents as they should be submitted. So we are very proactive in submitting those incidents. And if there is any incident that we obviously learn from it as they used to be used for learning curve, and we discuss them amongst ourselves if there is anything that we can all learn from it. So not everybody has to do the same mistake or have to do the mistake. So we do discuss them and learn from each other. So
great, thanks for that one answer. I think, you know, without as any of us knowing all the details, it's really difficult to answer it more fully. So I now have a question about surrogacy, and is it part of the broader commitment from Scottish clinics and NHS, Scottish NHS, to allow gay men to access surrogacy? There was a case that was widely reported, I think it was in 2019, and so is it available? Because he, as far as this person is aware, sorry, it's Marcin Smietana. Is it available? So I don't know who wants to take that one. Perhaps Abha, if you go, do you know the answer to this one?
Yeah, so surrogacy is available, and there is a surrogacy subgroup As we said, we have got lots of subgroup working on various things. So there is surrogacy subgroup, and we are trying to centralize the surrogacy and have a streamlined criteria. But any surrogacy does get discussed in the complex case subgroup that we have. We discuss the complex cases and the pathways made. So yes, it is available for those who need it.
Great, thank you.
NHS.
Okay, so I'm just sort of looking down my questions now. So this is one for Sally, but I think it's actually one that everyone might want to chip in on, which is, if the public were better educated about the mental and even the physical well-being of those who are unable to conceive, do you think that the issue would be viewed as seriously as a physical disability? And if this were the case, do you believe that more funding could become available for fertility services, or perhaps allow more free cycles of IVF for an increased number of people? And I think this is something that actually chimes a little bit with me, because many media interviews I've done over the years in campaigning for funding, it's something that's come up again, that people do not regard it as any form of mental or physical, they don't recognize the mental consequences, and they certainly don't accept it as a physical medical issue. So I think perhaps if we might go to Colin actually first of all with that one, to think if he thinks that would make a difference.
Yeah, I mean, I think it would. I mean, from a personal perspective, I took on chairmanship of the group, obviously being aware of IVF, but not something that I'd ever come in contact with particularly. Aware of friends having gone through it, but always being aware of the impact on people if you can't have a family, just understanding how all-pervading that can be. And I think that there is rightly a significant focus across the NHS and across life generally about the importance of mental health and what are the things that drive people to have poor mental health. And the NHS clearly has a lot of treatment commitments to people with mental health. So I think you've also got to look at it very positively, that if you provide IVF treatment, it potentially avoids you having to care for people in another way. And I do think more general public knowledge of it would be valuable, because I think a lot of people who take having children for granted because they don't realise what people go through when you can't have it.
Yeah. Gwenda, do you want to come in on this one?
Yeah, so I mean, even if you go back to our 2016 research that we did with Middlesex University, I mean, at that time it showed that 90% of people reported depression, 42% reported having suicidal thoughts. And we know even during COVID, a lot of people are talking to us when they're calling for that support about mental health. And we are just about to embark on a pilot, smaller scale study to start with around trauma. So I think that will be really interesting and really informative to see the results that come of that.
Yeah, that will be interesting. Does anyone else want to come in on this one? Sally, I know you've usually got strong views on this.
I do have strong views. A lot of people will know, but if you don't, then I spent most of a decade being an unsuccessful fertility patient, the first HFEA chair to be a patient. And we've tried to do everything we can, just in the way that Scotland have nationally over the last 10 years or so, to be able to put patients back at the heart of everything that we do and that's important. Gwenda referred to the research that exists, and people like Jackie Boyven in Cardiff and others are producing more information on the impact, mental and impact of infertility, but we could do with more research. It's a very private matter, isn't it? I think I just applaud Scotland for having recognised nationally what a difficult and traumatic time it can be when you're trying to conceive. And it would be nice if we both had further research and we could stretch that to the rest of the UK.
Great. So there's been a few questions related to consent following up from our earlier discussion, but I think people are seeming to answer their own questions there, which is great. But we seem to have an offer from Beverly Addison of free legal advice, which is always very welcome. As a former lawyer, I'm always looking for that. And so she says, I'm a fertility specialist solicitor working in Scotland. I've been trying to provide more pro bono outreach to the public on fertility law, as most of what people can access is written by people practicing in England. And how do the panel suggest we get this out there to the people that may need it? So what do you think, Gwenda, perhaps to go to you first, because you perhaps have the best idea for patient outreach?
Yeah, feel free to contact the charity and myself directly at Gwenda at fertilitynetworkuk.org, and I would be more than happy to speak to you about how we'd be able to disseminate that to the community.
Yeah, I think because people can, most of the time it's straightforward and people don't need legal advice, but there are some particular situations which we'll all be familiar with, where a bit of legal advice or something that people can read to make sure they fully understand things is really crucial. Now we have a question from Sarah Martins de Silva, which I'm going to take next, and this is sort of continuing really from the point that Colin made at the end of his presentation about sort of where next. And so Sarah Martins de Silva says, fertility services in Scotland are special, but we're not perfect. What do panel members see as important next steps to increase access to NHS funding? And then she gives a range of options, but you can pick your own, which is increase the limits on BMI to 32 or 35, to allow treatment for single patients, provision of surrogacy, treatment so that people can have a sibling for their first child, or standardized waiting times for donor eggs and sperm. So there's quite a menu there of things, but you may want to go for something else. So because Abha's smiling, I'm going to pick her first to go.
Sorry, that wasn't the case. I was smiling. So the access criteria was formulated, as I say, a wee while ago, and we know that the fertility landscape is changing. So one of the subgroups as a part of strategic fertility network will be an access criteria subgroup. So we'll look at the access criteria. And everything what we do, I mean, there is not an unlimited pot of money. We all realize it. And there has to be some sort of prioritization done for the right reasons. And a fair and equitable access is needed, with taking into account of equality and diversity. So the access criteria will relook at all these things and make recommendations accordingly. So there will be debates on all of these. Evidence will be looked at, and Sarah definitely will be part of that group to look at it. So she is volunteered as well currently.
Yes. And Gwenda, do you want to come in on that one?
So yeah, the next place I think absolutely we need to get right is definitely donor treatment, because there was a hold up at the National Centre, and it was all ready to go, but unfortunately, like many other things, COVID has got in the way. The BMI, well, you know, when that was looked at by the national group, the BMI also had to take into account the obstetrics risk and how that rose depending on how high your BMI was. And the evidence was absolute that it couldn't be argued with, that it certainly was quite an increase after 30. But I would echo Abha's points and what she's just said. I think that going forward, Scotland will improve further to be able to offer better provision.
And Colin, as you raise this issue, let's go to you and then we'll go to Sally.
Yeah, I mean, I think that the opportunity exists with the National Infertility Group and the strategic network to try and, first of all, I think influence policy. and understand through all the expertise that we've got is where would you naturally take this? Where would you increase accessibility? Where could you increase, but you know, what techniques could you use? How could you improve birth rates? All that kind of, anything, in my view, is anything can be improved. Nothing we do at the moment is perfect, and I've no idea, so I've got a real risk of saying something wrong here, but I bet you the birth rate 10 years ago was a lot lower than it is today, and that's because of all the improvements that everybody will have put in. And I also think the opportunity for us in Scotland through the infertility group and the strategic network is how can we potentially self-fund some of these things by wherever we can find efficiencies and do things better. We will be able to, I'm sure, through Scottish Government, keep that money to do other things. So that given the tight financial position, how do we try and self-generate some of our own funding to allow us to do some extra things that we'd all want to do?
And Sally.
Thank you, Sarah. Just a couple of quick things on stats. So Sarah, as she asked the question, will be involved in this, but Scotland already treats single women on the NHS. So numbers are small, but my figures tell me that for both donor insemination and IVF, there are single women who come forward for treatment. And the second thing I wanted to say more generally is that I think I referred to 60% NHS funding for Scotland. For people who aren't familiar with statistics, 60% might not sound like a very high number, but by comparison, Northern Ireland fund 45%, Wales fund 41%, and England now fund 35%. So don't be disheartened by the 60% for Scotland. It's at the top of the tree.